Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloane, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Segal, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education.
Welcome to Chapter 3 of What's Trending in Aesthetics. What's going on?
What a formal introduction. What's going on? Not too much. Today is admin day for me. What about yourself?
Admin day, client consulting day. Every day is the same. It's like Groundhog Day.
Groundhog Day.
Every day is the same.
Good.
Yes.
So, what have you been up to in the last week? Any interesting... You're going to a conference next week, aren't you?
I'm off to NSS, which is the non-surgical symposium up in the Gold Coast this Saturday. So I'm only there for one day. I'm mainly turning up to...
Schmooze?
To just look at the business-related chats, and I'm also doing a bit of work for a client up there as well. So I'm there for multiple reasons.
Very nice.
So, it'll be great to look at some of the business discussions, meet some of our patrons that are going to be there, connect with them. And there's a few partnerships and things that have sort of been bubbling away in the background. So it'll be good to actually meet some of these people in person and get a night in the Gold Coast. So
very nice.
Why not?
Where are you going to stay?
I'm staying at the hotel that's linked to the conference.
Is it in the Crown? Or?
Yes, I think so. I have to double check my tickets. Yeah, I think so.
Fair enough.
I've just bought them. Yeah,
Very nice.
That'll be fun. So I'm leaving. I've got a flight at 7 a.m. on Saturday, which will be great. I don't remember the last time I caught a plane at that time. So hopefully I don't miss it.
It'd be all right.
Be all right. And so, that'll be great. So I'm looking forward to that. Put up some content just today on a webinar that I looked at last week just on compliance here in Australia. So I just put a summary together. Mm-hmm. A lot of the stuff that's in there, most people probably aware of. Some of it maybe they haven't heard before, but I think it's just a nice little reminder for people to, I guess, make sure their I's are dotted, their T's are crossed in this new heavily regulated world that we exist in.
In Australia.
Yeah.
Cool.
Yeah, what about you?
Well, last week was very busy. Did a big event with Allergan, Australia and New Zealand.
That's right.
So there was a huge event in Bangkok, around 1,000 doctors and another, several hundred connecting from different countries around the world. Asia Pacific, should I say.
Yep.
And I did a talk that leads nicely in today's episode about, the summary was, what are the trends that we've seen in Australia and New Zealand over the last 10 years? But I guess my bottom line was that we saw a lot of facial overfilled syndrome. And it was inadvertent, it wasn't deliberate, it kind of just happened. And the lessons that we've learned from it and how we're avoiding it now.
Right, that's interesting.
Yeah, and I spoke via hologram. So I appeared as if I was in Bangkok, but I was actually a hologram. It was quite cool.
Yeah, well, I made a joke on our Patreon that no one laughed at because Tupac appeared as a hologram, and I said you were Dupac.
Yeah.
And no one laughed. Anyway, I thought it was funny in my head, so I said
maybe people would remember ABBA because they've done those concerts as holograms.
Right, okay, there you go.
Yeah, there you go. So that was interesting. So I don't know anything about holograms, but you're in a green screen room, a bit like how they film Gollum.
Yeah, right. Yeah.
And then, I'm just talking to a camera. So I guess what I would love if they could improve the technology would be for me to be able to see the crowd. So I feel like I'm actually interacting with the room. You might say a joke or just something funny, and yet you're talking deadpan to a camera and you have no idea how it's landing.
Yeah.
Nevertheless, it went really well, apparently. I got some nice feedback.
And do you have certain parameters that you have to walk within so you don't just wander off the
I literally
stage?
had to stay on the spot.
Oh, right, okay.
So if I looked wooden, because I literally wasn't allowed to move.
Oh, okay.
But it looked cool. I've seen some video from what the crowd saw, and it kind of looks like you're on stage.
And how long did your talk go for?
Just 15 minutes. Okay. And I was sort of interspersed with a couple of other countries talking about their own trends. So it wasn't too long, but it was good. And then, obviously the rest of the day was sort of Allergan centric, but that was nice.
Yep.
And then this Sunday, Monday, Tuesday coming, I'm at a big Juve event.
Yep.
So Juve are a big
we're going to that. Yeah.
sort of prescribing and sort of nurse support company. They help nurse injectors sort of run their businesses.
Yeah, we've had them on the podcast before, actually.
We have. I can't remember what episode it was.
Yeah, just look it up. If you go to our podcast channel and just type in Juve.
It'll be there somewhere.
You'll find it. Yeah, so we spoke to Melissa and Nicole. So shout out to them. Yeah, we'll be, when you said that, I'm like, that sounds familiar. Oh, yeah, I'm going to that.
Yeah. Well, you're going to the party. I'll see you at the party.
Oh, right. Okay. Yeah. I'm just coming for the good part.
Yeah. So Sunday I'm doing, I think it's about an hour's talk over dinner about my approach to consultation and try and inspire injectors to sort of take where their level is to a little bit further, hopefully. Obviously, there might be sort of more junior injectors, but maybe more intermediate, and then we'll do some live injecting after dinner. So that would be cool. And then Monday, Tuesday, sort of mentoring with smaller groups, and they will inject and I will mentor.
Oh, great. That's
so that'd
awesome.
be fun.
That's good.
Yeah.
And what's happening with Patreon this week for you?
This week, it's facial overfilled syndrome week. So I did a video, I found a video of Dr. Ting Som Lim, who I'm trying to get on the podcast.
Yeah.
So we'll do a whole podcast on this episode. But it was just about, his take on it, because he was the one who actually invented that phrase.
Yep.
And sort of his thoughts on how this whole thing has evolved. And, it's an interesting topic. So have you heard of it before?
Overfilled faces?
Facial overfilled syndrome, as in FOS.
No, I haven't. I wasn't familiar with the acronym, but I know that it's an issue.
Yeah. I mean, look, I think it's something that, even lay people would recognize. They see celebrities and they think, oh, yeah, I don't want that.
Yeah,
and that's the biggest problem. The perception is that is what filler is, and clearly it's not, because you see people who look great and they've had filler and they
just don't know.
Like
you only notice the freaks, right?
Well, exactly. You see the outliers and the most obvious ones. So
okay,
yeah.
So that's your Patreon post this week.
Correct.
Okay. Well, just a reminder for anyone, if you want to check out our Patreon, and if you don't know what Patreon is, it's a subscription-based or on-demand educational platform that allows us to give and deliver exclusive content to our members. We've also got a series of international WhatsApp groups. We've got hundreds and hundreds of people from all over the world who all share ideas, ask questions, help each other, support each other. So if you want to check out a 7-day free trial, you can do that. There'll be a link at the bottom of the podcast.
Yes.
And
yeah, check it out, guys.
Yep.
We get such nice feedback. It's great. People feel supported, and you got the most silly question. You just ask and someone will answer for you.
Yeah. No, as I said, every day I get up and there's like hundreds of messages, and
you don't read any of them, probably.
I do. I mainly read the business ones because I'm not really going to contribute much to things when it comes to medical side of things, but it's a hive of activity. But anyway, if you want to check it out, 7-day free trial, no obligation. If you hate us after 7 days, we'll try not to be offended. But anyway, so the topics we're going to be talking about today, the first one you alluded to, which was FOS, facial overfilled syndrome. What else is on the hit list?
We're shooting from the hip here. We don't have any research. We're just going to talk. I guess the opposite to it was this term Ozempic Face.
Oh, yeah.
So that's something that we can get into. I know a little bit about it, having read about it, and I've got patients who have gone through that journey, and some are in the middle of the journey and so on. The other one that I don't know if either of us know too much about, but you see this on Instagram and TikTok. You have influencers, I don't know who these people are, talking about things like face yoga and gua sha to improve not just, a bit of puffiness, but the shape of their face. And I guess we can throw into there, have you heard of mewing?
Yes.
Yeah, so there's mewing. That's kind of another thing that I'm actually really interested in, because I think there's some truth to it, but we'll talk about what is in the podcast.
Yeah, well, actually, my partner's been looking into some of this stuff. She's actually got a book. I might just go and grab it quickly and tell you what it's about. But it's even about the type of foods that we eat as children.
Yep.
The whole mewing thing of putting having like appropriate tongue posture, even the way that dentistry was carried out. Like I had teeth removed, and people's arches in their mouth are narrowing, which is constricting the sort of the breathing passages, and makes the face not look developed properly. And so a lot of that can be corrected, or some of it can be corrected with appropriate tongue posture. And so that's really interesting. She's looking into this now as well, because I think, as we're going to allude to in future episodes with regenerative health, everything's interconnected. And probably, again, the arrogance of us to think we know everything at the time, like, those ancient dental practices were not right. I mean, even before then, they used to pull people's teeth out and give them dentures without any understanding of bone absorption, and when you take the tooth away, what that's going to do to the bone in that area of the face and how that's going to affect you aesthetically. So anyway, interesting topic.
And if we've got enough time, we probably will. I don't know how much we're going to get into each of those topics. It's not really trending. It's just a newer topic. It's using ultrasound to do toxin regularly rather than filler.
Interesting.
So let's see how much of that we can get through.
I'm just going to grab that book quickly so we can reference it when it comes up.
I'll see you in a sec.
All right. So shall we kick off with FOS?
FOS. Okay. Well, I think the term is fairly obvious, but it's Well, let's take a step back. And I said this in my talk the other week. When people have filler for the first time, as long as it's obviously a positive result, they are very, very, very happy. They look in the mirror, they look, whatever it is, less tired, more contoured, less sad, whatever the outcome is. They are very happy with that. And so by definition, patients often go back for more because they want that dopamine hit again. And that's understandable. You've had filler, I've had filler. Yeah. I know how sort of pleasing it is to build on what you had and think, well, how much better can we get?
More is more.
Well, exactly. The patient's perception is, well, filler equals more happiness or more confidence or whatever it may be. And I think that's okay. That, that's the goal of the filler. And we shouldn't, there's also this trend that filler is bad now. And we've, and we're using it too much. And that sort of fits in with this whole overfilled syndrome sort of trend. But anyway, back, 10 years ago when people started probably filling more regularly, and we also saw this with lips and the Kylie Jenner trend. That was part of my talk. You have it done once and you think, cool, that looks more feminine, maybe more sensual. But at what point does it not look good? And that's the point. I think there's this perception drift. So at some point, both the injector and the patient lose sight of the overall picture of what the goal is. And that's the problem because of lack of clinical photography, of just having a clear goal, of, I'm not pointing fingers at any particular injector, but, you make money from this. So it's harder to say no than yes sometimes.
Yeah.
So that's how it all sort of evolves. So, any comments on that?
I mean, I think it's a really nuanced discussion because in some ways I do believe filler's been overused, and that's probably through pressure being put on injectors from patients who want more, and the reasons that you spoke about, perception drift, which for anyone that doesn't know what that means, it's almost like you forget what you used to look like, and the way you look now becomes the new normal. And you start to lose touch with reality, really. So there's that, and then I think it's injectors who, as we've said, this is a really new area of medicine, in inverted commas. Like, it's not something we've got decades and decades of history and data on to look back upon. We're learning as we go. So I think there's an element of that. And then also the fact that we didn't have that many tools. It was sort of like you had Toxin, you had filler for such a long time. There were some biostims, but, Profilo is relatively new. Sculpture's been around for a long time, but there's a lot of scariness around that. And also with any permanent filler like a Radius, which I think is also a great product, but there were a lot of people that were apprehensive. So filler became the drug of choice. And as you said, it's highly profitable, big turnover. It's an instant result, which people love.
Yeah.
And so I think all those ingredients led to a lot of instances of this overfilled face. I don't think you can point to any particular person or reason. I think it's a multifaceted problem that's manifest itself now 10 years down the track when we're seeing the results of years and years of filler upon filler upon filler.
Yeah.
And then you've got the other topic, which we haven't really covered in great detail, and hopefully we're going to get an expert on to talk about it soon, which is, what happens to the filler over time? Does it migrate? Does it get more hydrophilic? Does it start to change shape? And does it get bigger over time? And so are we starting to see now the long-term results of that? And I'm really looking forward to unpacking that discussion. But I think all those factors are probably at play.
Yeah, I actually think there's another element which is kind of obvious, but I think people don't realize how big an impact it's had. It's most patients are looking for an injector through social media or thereabouts. Most of them do. So you scroll through and you're on your homepage on Instagram and you might type on a hashtag lip filler Sydney and you're looking for a specific injector local to you. And assuming that you've looked for a particular type of liquid lip, which is traditionally a bit fuller, and then we went through that whole Russian lip phase, etc., you start to be served up a quite different, distorted normal, because everything is that. And then your peer group generally will have similar treatments to you, like your friend, your best friend, friends at work, and maybe even mum. And so your whole reality gets warped to this new normal. And that's, again, how perception drift, I think, happens, because everyone close to you buys into it. And what is really normal, your anatomical normal, becomes not good enough. So it's an interesting psychological sort of thing as well. It's not just injectors ramming it in, making money. I think there was also a societal kind of issue. And social media played a big part in that.
So then I guess the obvious question is what do we do about it, and how do we move forward as an industry to ensure that's not an issue and to sort of curtail this problem that we've now identified? I mean, what do you think the steps are that we need to take?
So something that I noticed, I don't know if every injector noticed this, but when we went into COVID, it was like this, well, hopefully it never happens again, that sort of unique time where we're all locked away, but also we can't access our treatments. So whether you liked it or not, you probably couldn't access treatments, at least here in Australia, for 8 or 9 months, probably. Yeah. I didn't work for about 8 months. So our patients were forced to sort of confront the reality of no Botox for 3 or 4 cycles and no filler, and also the unique thing of suddenly going on Zoom and seeing yourself dynamically, watching yourself talk, looking like crap with bad lighting on a Zoom call. And, lots of people did that for work. And so when my patients came back to see me, they were desperate for Botox, etc., but their motivations and their things that they were asking me in a good way changed, because instead of saying, can I have my lips done? They said, I've noticed I look tired. What can we do about that? And it became a much more holistic goal rather than, I want big lips, please. And now, of course, not every patient said that, but it was, as a generality, I noticed a big change. And so I guess the take-home point or the learning point is proper clinical photography and making your patient understand their face better. And we've spoken this a million times, and we actually have an IA offer with a photography company called Clinical Imaging if you want to actually do this in your own clinic. But I can't consult without photos now. And it's always the same. You meet new patients, they have no idea about their face, and some have good requests, some have unusual requests, but until you show them their face, it's arbitrary. It doesn't really mean anything. So I think COVID and moving to Zoom, and we noticed on the podcast, we've got to look at ourselves. We're on a screen right now, whereas we weren't doing that before. We were doing live interviews in this room with a guest. So you do become more in tune with what you look like, but I think in a more measured way, right? Rather than asking for arbitrary things from a static photo. Yeah, you're watching your face talk for an hour. Yeah,
I mean, how have you seen your injecting techniques and methodologies for approaching the face evolve over the last couple of years? Because, as you said, COVID taught us a lot of lessons, probably patience, if nothing else, and then all this information that's coming in now and these revelations and all these new tools that have come onto the market. So how has your practice changed in philosophies?
Well, it was actually, it was great because the patients suddenly aligned more with what I was trying to do before. And yet, and this is sort of a very MD codes kind of way of consulting for those who don't do the MD codes. What you're trying to do is tap into the patient's emotional motivations. So I look tired, I look saggy, I look angry, etc. But many patients, whilst they might look like that, they can't see it. They still want something random like bigger cheeks or, I don't know, a more square jawline for no real good reason, but they've seen it trend on Instagram. And so I was trying to get my patients to do this prior to, the whole Zoom boom and COVID. But once we moved to that phase where much more people were in tune with what they actually look like, it all made sense for them. Mm-hmm. So my consults probably haven't changed. They've got longer for sure. And I'm much more meticulous with the photos. So no one escapes my room now without, a good 15, 20 photos. And if anyone pushes back at that, I did have one patient last week actually, and I just said, well, we can't do this. And that's the end of the consultation because you're not willing to actually be consulted. And actually she was overfilled. So kind of a tricky sort of awkward conversation. But I think patients, once they understand why you're doing photos, because people are awkward on photos, they don't like it and I don't like it. But if they understand the process of why you're doing it and, you explain to them about everything that you're doing, their anatomy and what's changed, it makes sense. But until you get to that point, and I guess a lot of injectors don't do that, they find it a bit weird. Yeah, they're used to just jumping on a bed saying, "Oh, I have my frown done, please," and that's kind of the end of the consult. Yeah. So I think injectors are also learning; they're evolving. They're again, we've spoken about it a million times, but the consult has become more detailed and more nuanced and more focused on multiple outcomes rather than just, "Do you want your frown lines done today?"
Yeah. So do you find now that you are having consultations that talk about different modalities of treatment?
Well, yeah.
Where historically you might have just done filler. Have you found that the approach has maybe changed?
Well, yeah. And, we've seen in the last 2 or 3 years, we've got new products. So like you said, we had Profilo 2 years ago. We've now got Reduran. I don't personally use exosomes, but there are exosomes. We've got, of course, devices, lasers, M-faces, everything. Mm-hmm. And so at the end of those photos, of course, what you're trying to do is create a logical treatment plan.
Yeah.
So what I try and do, I'm not saying it's the right way, is I try and focus on a priority. I want my patient both to see a tangible result, but also maybe not go too overboard on the first treatment, because it's that first date thing. You're not going to go to fourth base on date 1, but also it's got to be affordable.
Yeah.
So when you treatment plan, it's not just about what do you want? It's got to make sense from a safety, downtime, budget perspective. But then, of course, you need to lay out all the options. So if their priority is, sagging, and they're quite volume deplete, that's hard. And it's not an easy win on day 1, but you might move to something like a biostimulator first to try and firm up that tissue, get a bit of collagen stimulation over a couple of months, and then do something easy like Botox just on that first setting.
Yeah.
But then treatment plan for more structural filler down the line.
Yeah.
So you're trying to get your patient to understand, well, what are these tools, and why am I suggesting them? It can't just be the one that they've heard of. It's got to make sense. Yeah. And it's getting more confusing. I had an injector shadow me yesterday, and we were talking. It's getting complicated for injectors. There are so many products. Some of them sort of overlap. So biostimulators, bioregenerators, bioremodelers, skin boosters. There's a little bit of overlap of all of these, but I think you need to explain to your patient why you've plucked one and not the other. Because, even though we can't advertise in Australia, they're going to get all their information from somewhere. And if you don't explain it properly and exactly explain not just why you've chosen it, but what is the goal and what to expect, they just get bored of it, because some of these things take time. They take months to show an effect.
Yeah.
Like, sculpture or something like that.
Yeah. Yeah, I think it's a good idea to sort of break up the different stages of the treatment plan. So, Botox or anti-wrinkle is something you can do on day 1. It's a nice instant result. It's relatively benign treatment in terms of complications, maybe a bruise or some asymmetry, but what have you. So it's a nice way to get an easy win straight away.
You build trust with them as well.
Correct, yeah. And then I think if I was a practitioner, which I'm not, but if I was, for me, then I'd go, well, let's address, the filler would probably be the last thing I would do.
Yeah.
Knowing what I know now, because I want to get the canvas better first.
Yeah.
Because the paint, it's like a painting. The paint's going to take better to a better canvas than a floppy one.
But by the way, not everyone needs that. If you're younger or you've got better tissue.
I guess to check if it's applicable.
Yes, yeah, for sure.
And then just colour, tone, so lasers, and then I'd probably go filler would be like the icing on the cake for me.
Yeah.
Really. But I think part of the problem, the challenge is that we've just, Botox or, toxins are almost instantaneous, like a week, really. It's not like there's not a long period of time to wait for maximum result.
Yeah.
As compared to biostims, which there's no immediate wow factor. I mean, with Sculpture and Radius, obviously there's a carrier which can give you some kind of idea what it's going to look like.
It's kind of nice. That first week you almost get the end result, but then it disappears.
Yeah.
So at least you can say, that's what we're building to.
Yeah.
But it doesn't last.
Yeah. But I kind of think practitioners potentially struggle with getting that over the line in terms of getting the patient to accept that it's not going to be an instant result and you might look good for a few days and you're going to look deflated again.
Yeah.
Because it's not like it's there and then it's not there.
Yeah. But, but if you are an injector listening to this and maybe you're more junior or less experienced, that is the point where you need to stick to your guns and not go, oh, okay, we'll do something different because you want it.
Yeah.
It's got to be a logical plan. And if your patient can't follow it, but, you know that is the right treatment, just say no.
Can you imagine going to court and your lawyer says, look, this is the plan. We're going to do this first. You're like, no. We're not entering pleas now. We're going to, it's like, what the hell?
Yeah.
You want my advice or you don't want my advice?
Yeah. Yeah. And of course, there's not always just one way, but
no, of course.
I think it's worth being clear with your treatment plan.
Yeah.
What are the goals and map it out for them over a year. I mean, I should do this. I don't send them sort of the plan, but tell them every 4 months I'm going to see you for tox, interspersed we're going to do, X, Y, or Z. And maybe show them what that budget looks like, because if they can't do it or it's just too unaffordable, then you need to have a plan B or something different. But you can't not be truthful with people.
Yeah, for sure. Yeah, you have to be upfront and honest and let people know what the expectation is. And that way, at least if you've mapped it out, they can have an opportunity to budget for it. They can work it into their annual budget and makes it much more affordable for people. With the photography as well, I just wanted to just wheel back to that for a second. Is just even for getting the consultation process, legally, the amount of times that having good clinical photography saves your butt from potential litigation and patients that come back in and say, well, this line wasn't here before, or that wasn't there before, or your result didn't work. If you don't have good photos, like, it's going to be tough for you to defend that accusation.
Very tough. And, sometimes I've definitely needed it in that circumstance. So super helpful. But mainly it's, I can't remember what my face looked like a week ago, let alone my patients understand. So I would actually say the majority will not understand the result of a treatment unless you show them. It shouldn't be a default that they will just know.
Yeah.
You should actually accept that most of them won't know.
Yeah.
And without the photo, you'll get lots of disappointed or litigious patients.
Yeah.
I would think it the other way around,
Yeah. Okay, so getting back to the overfilled face. So you've identified the person that's got filler up the yin-yang and you need to potentially get rid of it, or I don't know. This is where I'm going to get you to tell me what you do, but like, what do you do when you're presented with that overfilled face? And, how do you sort of plan for that? Is it a case of total dissolving strategies and waiting for it all to subside and then starting again? And is that even really the best way to do it? I mean, can you dissolve it all? Is it just break apart and then disperse all over the face? Like, is it actually really dissolving so there's none left? Like, what's the process?
Actually, I don't have an answer anymore. I've dealt with this for a couple of years now, and patients come and they book in and they quite understandably want an experienced injector for a second opinion, and they're not happy with their work or they're overfilled. And sure, I mean, I'll give you an example. The patient last week, she was definitely overfilled. She knew she was overfilled, and her lip was terrible, like distorted, big, migrated, puffy, just asymmetrical, just everything.
And do you think that was bad injecting, or do you think that's a function of time?
Look, I don't think that she was willing to be totally truthful, but she essentially said, I can see it's not good, but I don't think she was being truthful with how many times it had been done or why it had been done. I got the impression that maybe she'd bullied some injectors to do more and more and got to the point where even she thought, oh my God, I've pushed this too far. And maybe they said, well, I've had enough, go and see someone else. I don't know. I'm just speculating here, so... but it's tricky because they come to you as the injector, even if they fully acknowledge that they are overfilled and they want to do something about it, because sometimes the awkward thing is they don't see it and they're asking you for more stuff, and that's very you've got to be very delicate about that. But you've got to be honest and stick to your guns and say, well, these are the reasons why I won't. But to take on the challenge of actually, maybe dissolving someone, it's very difficult. And very often they're disappointed with what they look like. And I don't really have an answer as to at what point do you accept that overfilled is better than completely deflated? Because, they're going to be very upset with that. I don't know. I think it's on a case-by-case basis. And, I try and suss out how willing the patient is to go through a bit of a journey. It's not going to be a one-off, magic overnight and then we'll refill you next week. It doesn't work like that. You've got overstretched edematous tissue that potentially has been there for 10 years or many years, layers of filler. And even if, with the best will in the world, you can only do so much high layers at a time. So maybe you would break it down into particular areas at a time just to make it more manageable. I don't know. And inevitably you don't get it all. If you put a scanner on someone's face, which I do regularly to just have a look, I actually do this with the overfilled patients. Sometimes if they're not quite sure, I'll put the scanner on, I'll show them the filler. So at least there's some objectivity to, well, that black stuff, that's your filler. So at least, I'm not bullshitting you. It's there. I can see it. And you can talk to them a little bit about the depth of the filler. So if it's very superficial, where in my opinion it shouldn't be, you can at least say, well, look, maybe on round 1 of dissolving, we'll sort of chip away at the top layer of the onion and just do the superficial filler and sort of leave what's deep. I mean, it's not really a true science. It's a liquid. It will go where it wants, but you can try and be a little bit more strategic. But it's very difficult. And I don't know, I'm getting more and more, not defensive, but saying to these people before we commit to anything, are you really sure you want to do this? And here are the 3 options: do nothing, dissolve, or go and see someone else. Before I've met them, I'll reach out and say that to them, because it does get litigious. If you make someone's face worse, saggy, jowly, in their opinion, you've dissolved their natural, HA because that's what they've read on Google, suddenly it gets very, very tricky. Yeah. Oof. So it's a real problem. Because, other injectors inherit other people's work. So it's one thing if I've overfilled someone, well, sure, I would probably be more happy to tackle that, which is pretty rare, but I'm not going to say I've never done it. Of course I have. We all learn as injectors. But if you inherit someone else's patient with facial overfilled syndrome, the first thing I say is, well, why don't you just go back to who you saw? You've obviously had a rapport with them and you did rounds and rounds of filler. I know you're not happy, but it's actually easier with them. They know what product you had, what plane it is, how much you had. Why not just have that conversation with them?
It's a minefield, isn't it? Because you're right. Yeah, like you could dissolve all this filler out of people, and all of a sudden you've revealed what they actually look like, but they haven't been aware of what they look like because it's been masked with filler for 10 years.
Correct.
And then all of a sudden you're public enemy number 1, and you're getting letters from lawyers. And
yeah.
And how do you ever prove that you didn't do that, or that you're not the cause for that? I mean, because there are enough people out there, people within our industry, who claim that filler can eat your own HA.
Yeah.
So there's enough people out there making those noises that you would not blame a patient for saying, well, is that what's happened to me?
Yeah, I'm happy to talk about this. Maybe less than a year ago, I had a patient I inherited from another clinic here in Sydney, well-known clinic, and they had been doing treatments for closer to 10 years on her, including a non-dissolvable filler, I won't name the filler, around her mouth, which is not where you would generally put this filler normally, a non-dissolvable filler, because it can accumulate and cause lumps and bumps and just look crap. Anyway, she did have some little lumps and bumps, and that was the main reason she sought my help. And she'd already been told by the other clinic, it's not dissolvable, really sorry, we'll kind of chip away and do some stuff. And they did try 3 dissolves and basically nothing happened.
So they were those collagen lumps, obviously.
Yes.
Yeah, okay.
And I'll keep the story very short, but I ultrasounded the area first and identified, well, yeah, those are your lumps, and it's not HA, it's something else, so it's your biostimulatory type filler. You've already tried 3 dissolves, so, not being funny, but why do you want a 4th from me? It hasn't worked. And they know what they did and I don't. Anyway, she said, look, I'm here now, let's just try. And I thought it was all very amicable and nice. And so I said, okay, we'll try. And very clearly said, it's probably not going to work. And so we did it. You can see the lump. We didn't need ultrasound or anything. We just tried to dissolve it sort of into the lump, and lo and behold, 2 weeks later, nothing happened. But at that point, I get an email from the patient saying, I'm not very happy. I've still got the lumps, and this time I want you to use the ultrasound to dissolve them, which is what I booked for originally. And I said, well, within, reason and being sort of, polite here, that's not what was discussed. But also, I wasn't the one who did this, and you don't need ultrasound to inject a lump that you can see visibly from the you can see it. You could inject it. It's pretty obvious. So we sort of went round and around the houses with back and forth emails, and to cut a long story short, and I don't want to be sued, but she took me to what's called a tribunal.
Oh my God.
And
so was it an HCCC complaint?
Well, that as well.
Jeez.
But long story cut short, nothing happened, and they sort of saw my side of the story. But my point being that patients don't care who was right. They just want, in their words, justice. Someone is to blame, and if it wasn't the other injector, it's my problem. So, if you're listening as an injector and you routinely dissolve other people's work, be careful. It's not easy, especially when there's a complicated story of years and years of, different types of filler and non-dissolvable filler. And, patients have now read that, ultrasound is a thing, and they decide in their head what ultrasound shouldn't be used for. They're now the expert of ultrasound, as well as Hyalase, as well as the consequences of Hyalase.
I do wonder whether or not yet another consent form that is specifically designed for trying remedial work on other people's screw-ups, basically. So does it need to be more overt? Does it need to be more stated that I'm doing this treatment, you've come to me with complaints from your previous practitioner, this is what you've presented with, this is what we're going to attempt today. I, as the patient, know and agree that this may not work. I potentially could look worse. I will not hold doctor or nurse so-and-so liable for something. I don't know. I'm not a lawyer, but I just think maybe it needs to be something as overt and really
I basically have that.
You do?
I don't know if I've got the actual clause of someone else stuffed up your face, but the rest of it is there. I've got like a proper dissolving consent form.
Yeah.
And, it was all signed and all discussed and all done. And, the other stupid thing about this case that I just discussed was, this person was intelligent. She's not a doctor or a nurse, but she's a healthcare professional. And she would have known just by lying there that I didn't dissolve her with an ultrasound device because it wasn't on her face. and we discussed the fact that we weren't using it. So to then sort of retrospectively complain to say, oh, I want the thing that I wanted, i.e. ultrasound guided dissolving, is kind of silly because you would have known on the day that didn't happen. So it's almost like complaining that you didn't, I don't know, you're still hungry, but you only bought an appetizer, but you're still hungry. It's a stupid sort of thing, right?
So what would your advice be to practitioners that have patients that book in with them? Well, is it easy just to say no and say, look, sorry?
It definitely is easy to say no. That's true. Now, rightly or wrongly, and maybe I'll change my mind as time goes on, I've sort of decided, look, I'm quite experienced. I have some knowledge of using ultrasound. I'm probably better placed than many injectors to at least try and help people when there's a real need. Not everyone comes litigious. Some people come with a really bad problem and I can help them. I've got another example. A woman had tear trough filler several years ago, yet again at a very reputable clinic. I've got nothing against the clinic, but, complications happen. And she had a one-sided eye bag for years, like 3 or 4 years. And she was told by that clinic, well, that's just how you are. It's not the filler, it's just you're getting old. And so I took one look at her, heard the story and said, I think what's happened is you've got filler, it's called post-septal, it's under your eyeball, it's sort of too deep. And so it's creating this sort of puffy look. So when they tried to Hyalase her, nothing happened. But that's because the Hyalase isn't in the right compartment. Anyway, I said, look, I know this sounds crazy, but you need an MRI to prove this. She goes off, gets an MRI. She's got post-septal filler. So under a bit of instruction from Mobin, our friend Mobin, we did a post-septal dissolve. So I put basically a needle under her eyeball and did Hyalase. And within a week, she's sorted.
Wow.
So sometimes there's a happy ending to this, is I guess what I'm saying. But it's not for the faint-hearted. And I don't think, and the other thing I notice is injectors charge really cheaply for it.
Yeah, right.
They're charging like, $250 for a bit of Hyalase from a stuff that wasn't theirs. That pays for my consult, but it doesn't pay for the ultrasound or the dissolving.
Or the headaches, potentially.
Or the stress and the drama and the emails.
So what do you think people should be charging for this?
Well, I don't know. Look, everyone's got a different price, but more than that. You'd charge more for a glabella toxin.
If I was an injector and I was being presented with other people's issues that needed resolving, I probably wouldn't do it for under $1,000.
Right. Well, mine's close to that. And people balk at it. They're like,
we'll go somewhere else.
I'm like, it's up to you. I don't bring you here with a gun to your head. You sort me out because, I have some skill in this.
Yeah.
So, it's not take it or leave it, but it kind of is, I
think it is take it or leave it. You have a right to say yes or no, just as they have a right to pick their provider.
Yeah.
And if you're going to take on someone else's issues, then it's got to be worth your time because for all the easy, nice cases that you had with this post-septal filler patient, how many, every so often you're going to get like a nightmare that's going to cause you issues, and you've got to allow for that in terms of time. You've got to be compensated appropriately for that, because a certain percentage of them will take up a lot of your time and stress you out. So, and then also maybe that sort of price tag will encourage people to say, maybe we'll go back to the original injector.
I have to be honest, that's partly why I'm priced that way. It's not, to push people away, but do you really want to do this?
Yeah.
And actually, I always get my receptionist or if I get the email myself to, in that sort of first response before they've booked in, to say, have you actually spoken to the other clinic? Because they might do it for free.
Yeah.
They might do.
Yeah.
And that saves everyone feeling hard done by.
I think definitely don't sell yourself short on that, because there's a lot of upside to charging appropriately. So, all right, well, let's jump to the other end of the spectrum now, which is the Ozempic Face, which is the antithesis of FOS.
Well, in a way, yeah. First of all, Ozempic, do you know what it is?
Yeah, it's a weight loss. Slows down gastric emptying, slows down suppresses your appetite because it slows down your digestive processes.
Yeah, so that's its, I guess, second mechanism. So Ozempic is a semaglutide.
Yep.
It's a type of drug. Its main action, it's a GLP-1 agonist. There's a hormone, basically, and GLP-1 naturally makes you feel full.
Yeah.
So if it's an agonist, it's sort of artificially making you feel full. Plus, like you said, it slows down your gastric emptying, so you just, your stomach's fuller for longer. Anyway, so people have been taking Ozempic since, I think, 2017 in the States. It was approved by the FDA. And, it's actually, I'm not sitting here promoting drugs, but it's an amazing drug in terms of it's been very successful. People have lost a lot of weight. It was initially licensed for diabetics or type 2 diabetics, and it's got their sugars under control. So it does have an influence on insulin production, and therefore it reduces your blood glucose as well. So anyway, amazing sort of results for the diabetics and those people losing lots of weight. But I guess one of the consequences that people started to see was, of course, if your whole body is losing fat and weight, the face loses weight. And so this, I think, kind of unkind term started going around that you have Ozempic face. So it kind of implies that the drug specifically has done something to your face. Whereas actually, it's just you've lost a lot of weight. Mm-hmm. So, I mean, I've got no evidence to say that Ozempic targets fat on your face because you lose, your whole body weight.
Well, people have different predispositions to where they're going to lose fat from.
Yeah.
And also that changes during the aging process as well. Like with hormones, like your body's distribution of fat cells and where you're going to lose fat from changes as the body ages. And you've got genetic predispositions. Some people carry a lot of fat on their butts. Some people carry it on their face. And
that's true. And you see racial differences as well.
And so it's fat cells, right? So the less fat cells you have in an area, the more dramatic it's going to be when you lose weight, as opposed to somewhere that has less fat cells.
Yeah. But I guess, again, I can't speak for every single case, but people on a successful sort of Ozempic journey with the goal to lose weight and obviously control their sugars, they lose about 10 to 15% of their body mass.
Over what period?
Look, most people would be on it for around 12 months, but, every case is different. But, often the first 3 or 4 months is rapid because, suddenly your body is, eating less calories, basically.
Yeah.
And so it can be relatively quick, at least in the first few months, and then you stabilize. But I've not read a single case where it's just been on the face. It's always been the whole body weight has been 10 to 15%. So, it's not just Ozempic. There are other drugs like Mounjaro and Wegovy. These are all licensed for weight loss, but it became known as Ozempic Face. But the same effect is the same for bariatric surgery.
Yeah.
If you lose a lot of weight, your skin, especially on your body, gets saggy, and it can be a real problem. You might need that skin trimmed away in massive bariatric weight loss. We did a podcast on this years ago with can't remember his name. Lovely guy in Edgecliff, Jeremy Hunt, Dr. Jeremy Hunt.
Yes.
And we spoke about that. What happens, with the consequences of losing a lot of weight? You need to trim the skin, because if it's that loose and sort of floppy, if you like, it can obviously be disfiguring, but it can chafe. You can get infections in the skin folds because it just collects sweat and stuff. It's not nice for patients. But back to Ozempic Face. Basically, you look like you've lost weight, but you can look a little bit hollow, a bit gaunt, maybe a bit saggier, maybe more tired. All of the above. It's everything expected with losing weight. But, so this stuff was sort of trending on Instagram and TikTok and so on, maybe a year or two ago. I think people have just accepted now that it's not really a drug thing. It's just a weight loss thing. But interestingly, I was watching Maurizio De Mao to do a presentation about a week ago, and his patient was on Ozempic. He was talking about the fact that she started Ozempic. And so his treatment plan was to try and, I guess, put the building blocks in place to prevent Ozempic Face. It was interesting.
So like a prophylactic filler.
Yeah, but using a biostimulator, not an HA.
Oh, okay, yeah.
Well, combination.
Like a sculpture or something? Or
so it's called Harmonica.
Right, okay.
So it's an Allergan sort of biostimulator. But I guess the relevance of us talking about this is injectors are going to see people on this drug. It's very common now. It's actually quite hard to get hold of in Australia, but only because it's so popular. There are lots of people on it.
Now the diabetics can't get it because all the...
Well, yeah. I mean, if a doctor's happy to prescribe it off-label, then so be it.
Yeah.
I guess you can't account for that. But a very successful drug. But, if you're an injector and you do encounter someone on Ozempic, it's worth having that chat, especially if they're early in their journey, it hasn't happened yet. So, again, that talk about, well, you're going to look thinner, obviously, but how do we maybe anticipate that by getting your word, the canvas better before it gets saggy? It's definitely a conversation to have, and I think it will become more and more topical and common as the drug sort of grows and it becomes more common.
And I wonder, is there any evidence to suggest that the rate at which you lose the weight will impact how much your face looks Ozempic-y? Is that a thing?
Well, I think, if let's say you're sick, or terrible example, but people who have cancer, they lose weight rapidly.
Yeah.
And I guess rapid weight loss doesn't allow the skin to sort of recoil. It just loses its elasticity because it's just been too quick.
Yeah.
The skin doesn't sort of come back with it.
Yeah.
But I do think there's a point where, especially in the body, you see people with stretch marks because of the obesity. Yeah. Mm-hmm. That is a sign that you've basically disrupted the elastic fibers. They've been broken. That's what a stretch mark is. So I think, no will or preemptive treatments in the world are going to get that to snap back.
Yeah.
It's just an inevitable. You're going to look a bit saggy after, and maybe you'll have a abdominoplasty or something.
Right.
But on the face, it doesn't tend to be as dramatic as that because how big can a face get? I mean, I'm sure there's some big, interesting examples, but generally you look like you've lost weight in the face, but you're not that bad.
Yeah.
But you can look a bit tired, a bit haggard.
Yeah.
Not quite as rosy or youthful. And so if you're an injector, think about that and think about, well, which fat compartments might you preemptively treat? What stimulator might you use to counteract that sagginess and talk about it explicitly with your patients.
Yeah, as you said, it's going to become more and more common.
Yeah. Let's get on to mewing. I really like this topic.
Okay. Sure.
Okay, I'll tell you what I think is mewing, and you can fill in the gaps because you've got a book there.
Yeah.
So mewing, it's a term that's been trending mainly on TikTok where, like you said earlier in the podcast, it's the act of sort of exercising your tongue by holding it to the roof of your palate, and not just at the front, but the key is to get the back of your tongue to the back of your palate.
I'm mewing right now.
Are you? Mm. Oh, you look great. But what happens when you see someone mew properly, you see that the floor of their mouth tends to tighten and you get sort of a better jawline. Mm-hmm. It's quite hard to do actively, I think. You've really got to think, well, I have to think about it. I don't know about you, but I have to really think about it.
So all I do is just hold my tongue in my mouth normally and swallow. And when you swallow, it creates a vacuum.
Correct, and then you keep it there.
And you just hold it there.
Yes.
Yeah. So, I mean, I just try and be conscious of it for a few, when I go for a walk every day, and while I'm doing that, I'm just consciously saying, do it, because,
Do you know why it's called mewing?
Because it was named after a guy that invented it?
Yes.
Yeah.
Who?
Someone Mew.
I know the story. I went down a real rabbit warren.
Is his name George?
No. So John Mew.
Oh, yes, that's right.
Is a British orthodontist. He's in his 90s now. Yeah. And he came up with the concept and, this, I don't know when he was practicing. It must have been in like the 60s and 70s, a long time ago. And I think in the orthodontic society or community, he wasn't seen as very, he was seen as a bit of a quack. And people didn't believe him. So still to this day, most orthodontists would use, traditional braces to move your teeth, or like you had, remove your teeth and sort of basically pull your jaw and teeth back into place mechanically. That's him.
His name is Mike, not John.
No, that's his son.
Oh, it's his son.
This
is Junior Mew.
Yeah.
Yeah, right.
So Mike Mew, Mike, if you're listening, hello. I've been trying to get you on the podcast, but I don't have your number to get hold of you. He has sort of taken on the baton. Right. And he has come under real heat from British Orthodontic Society because they think he's a quack and he's talking rubbish.
Science does this to everybody that comes up with a new idea, whether they be an archaeologist, a doctor, a scientist. It's just, if you're challenging the status quo or the thought processes of people, for some reason, it just almost becomes a personal vendetta against these people because you're somehow going to discredit the discipline because now other people's philosophies and thought process are now going to be updated.
Yeah.
But that's just science.
Well,
they go after these people. I've seen it with like other people, like, archaeologists. And it's just like, there's so much aggressiveness about it. Like, don't we want to get better as a species?
Yeah. Anyway, so I've watched a lot of his videos and it's very interesting. So what is the purpose of mewing? So if you force your tongue to the roof of your mouth, and especially at the back, you expand your palate by force. And, it's a small, but it's a significant and I guess continuous force if you're doing it regularly. And so the point of that is a lot of children now, and funny enough, my son went to the dentist today to talk about some of this, but if you have a child with quite a narrow palate, they tend to be mouth breathers. They can sleep badly, ultimately ending up in sleep apnea and bad snoring. That has effect on growth, but also facial growth and even aesthetics. So this is why it fascinates me, because I'm like, hold on, your teeth and your tongue change how handsome you are, which is basically what Mike Mew says. He says that if you mew and you think about your tongue posture, you will be more attractive. Now, that's not the end goal. The end goal is to breathe better, but it's a nice benefit because your facial bones and your maxilla will develop differently as opposed to having a narrow palate, narrow teeth, and sort of a backwards facing chin that doesn't develop properly. So is that a good summary of
I think
mewing?
so. Yeah. And as I said, like now I think orthodontic practices or some orthodontists are now taking the approach of putting in palate expanders rather than, because people will present to the orthodontist with crowding and misshapen smiles and so on, and generally because the mouth hasn't grown big enough to accommodate all the teeth, so they just used to pull out all the teeth and then put braces on.
Yes.
Whereas it's like, well, no, let's actually make your palate the appropriate size for your face
Well,
that you can accommodate these teeth. It seems common sense, but it wasn't common sense 10, 15, 20 years ago.
Common sense isn't common.
They should rename it, actually. So, I mean, it's fascinating. I mean, I've seen a lot of people talking about it online, and when at first blush, you just sort of think, what the hell? You're just going to stick your tongue in your roof of your mouth and you're going to become better looking. How does that work?
Well, I mean, again, I don't know who is right and wrong, but if you look at the case studies of Mike Mew and, just see these kids who have been under his care, you can see their face shape is much more aesthetically pleasing, but of course, functionally, it's better. And, the other issue is if you've got a narrow palate, you're also constricting your nasal cavity. Hence, people are mouth breathers because they can't breathe through their nose. It's congested. And it also has an impact on your sinus drainage. So it's fascinating.
Too many people do breathe through their mouth.
I tell you where, I think Mike was criticized because he's got theories about how we've evolved, and it's to do with our diet. And I don't know if it's pseudoscience or real or not, but he's saying because we have a soft diet now, we give babies baby food, and we don't tend to eat sort of a lot of roughage, and we don't eat like cavemen, and we don't chew on bones, all that kind of stuff. Because our diet is basically soft, we don't have to chew, and so we don't use the tongue and our muscles of mastication as effectively.
I don't know why that would be controversial.
Well, it sounds logical. I just don't know if it's true.
Well,
it's just a sort of a theory. I don't know if it's true.
Well, I mean, what else is causing this sort of almost feminization or over? Like you don't see the same number of people walking around with those. I think as a species, we're like seeing the faces become more and more delicate is what I'm trying to say over time. You don't see like that, the robust facial structure, particularly in men, that we're used to.
He'll use the example of if you look at, I don't know, African tribes or any tribe that live off the land, they generally have pretty good teeth.
Yeah.
They don't have crooked teeth. That's his big thing. He's like, it's just diet and sort of habits.
It makes sense to me. I mean, if you're not using the body the way it's supposed to be used, then it's not going to develop properly.
And of course, dummies or pacifiers if you're in America, that sort of stuff, and thumb sucking, it screws up your teeth.
Yeah.
And that has a big impact. So, we didn't give babies dummies when we were cavemen. Probably. I doubt we did.
Yeah.
So it's all that kind of stuff as well.
Yeah. So which is kind of weird because, as I said, my partner was looking into this and she's got a book here. It's called Beauty is Bone Deep. Learn how to grow a beautiful face, plus why doing so sustains health of the body and mind, by a lady called Katrina Fay.
Yeah.
And as you said, there's a foreword in here by Mike Mew. And I mean, I can read the blurb if you want at the back.
Well, joking aside, if anyone knows Mike Mew, please contact us because I'd love to get him on the podcast. It'd be a fascinating chat. I actually was talking about this yesterday with someone who was shadowing me. So, patient, long, narrow face, tired looking, has already had braces, Invisalign, and teeth still aren't right. And, aesthetically, when you look at someone, if someone is quite, long and narrow, they'll often have a smaller chin, which makes them look less contoured, and maybe their mentalis is engaged and they get that sort of dimply chin. But also because they've got underdevelopment of their maxilla, their cheekbone, they often look tired. And so they're prone to sort of darkness, dark circles, or just being a bit flat. So again, aesthetically, we can improve that with filler, etc. But they need to see a dentist. And it's worth having a chat because some of these people might have just gone their whole life having no idea. And, again, a lot of dentists might push back at some of that, but seek out maybe a more holistic dentist that knows a bit about it.
Well, it's like anything. Go and get multiple opinions.
Yeah, yeah. But, it will help their bite, their sleep, their health, as well as their aesthetic.
Yeah. I mean, I know, as soon as I get sick and I can't breathe through my nose, I notice it and you just feel, I don't know. It doesn't feel right. Yeah. It doesn't feel right. So what was the gua sha stuff you were talking about?
Well, look, I don't know much about this, but everyone would have come across these TikToks or Instagram of some sort of influence, I don't know what their background is, talking about facial yoga.
Yeah.
And using gua sha, which is kind of like a piece of jade to sort of massage their face and do lymphatic drainage. And again, I don't have all the answers, but it seems highly unlikely that rubbing your face or doing some stretches with, just your hands or stretching your jaw is going to get rid of your jowls. But this is what is proposed by the influencer. And if you look at the comments, there's a ton of people engaging with this stuff, investing in products that are being sold. Even if it's just a piece of jade or a course to learn how to do facial yoga. Personally, I think it's snake oil. I'm just going to put my neck out and say I think it's bullshit. But
we should get someone on who has a contrary opinion to that.
Well, yes, we should.
Debate.
We'll get the face yoga person on.
Yeah.
But again, I don't have all the answers. Maybe there's something in it, but taking it to the extreme example, we've done a podcast on something called Face, which is a device that stimulates the smiling muscles of your face to lift or get an apparent lift, as well as toning the skin with RF. So to me, that kind of makes sense. You're improving the canvas and you're tightening the muscles that lift up. And, I don't have an Face in my clinic, but lots of people we know do, and they're really happy. So I guess the proof is there. But these machines, they're stimulating your muscle far, to a degree that you can't do naturally. You can smile all you like, but something like Face does it, significantly more and more powerfully.
Yeah. Well, I guess as long as these treatments aren't ridiculously expensive and they're not hurting anyone, then maybe there is some benefit, but it's not to the same extent that something like a device would have. But
yeah, it's fine if it doesn't hurt you, but I feel like we're dealing with, well, we're trying to deal with science here and get to the root of all truth here on this podcast. So if you don't have some sort of evidence to back up what you're telling people, and of course they're using the before and afters in dark and light and it all looks better, I think that's, it's deceptive and it's kind of wrong.
Yeah.
And a lot of people are, even if it's a small amount of money, they're investing in something to improve it or just wasting their time.
Yeah. Well, let's get a contrary opinion on to talk about it. So if you're that person or you know who that person is, let's get in touch and we'll have the...
I'm amazed you've never done it. You're that type of person who would...
I've done massage when I've had a flu to like help drain.
Yeah.
I found it helpful. But
yeah, I think that makes sense.
But in terms of like facial yoga, I haven't tried that, no.
Okay. Fair enough.
But hey, watch this space. Maybe we'll be wrong. Maybe we'll...
Again, if anyone knows anyone who's an expert in this type of stuff, let us know. I'd love to know. And in fact, you've reminded me, guys, at the bottom of the podcast description, we have a new WhatsApp group for any of you who want to talk to us, whether it's a comment, you've got, Mike Mew's details, or you just want to say hi and introduce yourself. Please join that WhatsApp group. We want to know who you are, and it'd be nice to be better connected with you. So just join our WhatsApp group.
Absolutely. I don't think we've got much more to discuss. I think we covered nice 3 chunky topics there on what's trending. I think a large portion of that chat was taken up by the Overfilled faces, but that's probably the biggest issue that we're facing at the moment.
Yeah.
In terms of what's the word I'm looking for? Outcomes that we don't want.
Yeah, 100%. But I did have on our list, but I'm going to save this for another podcast. It was... it's not really a trend. It's something that I guess is evolving over time, but people specializing in using ultrasound to use toxin, not filler.
Oh.
So that's something, do you know what? We'll do a Tox Talks on it. I'll get someone in who's doing it regularly and we'll talk about their experience in using ultrasound for toxin. I think that will be something that's going to grow, and it might sound a bit fiddly and a bit silly because, there are lots of people not even using ultrasound, let alone doing it for Botox. But if you think about it logically, you're squirting in a toxin to try and paralyze a muscle.
Yeah.
Yeah. How do we really know that toxin is in the muscle? And maybe you could use less units and get better results.
Yeah. Maybe.
So,
I mean, look.
And less complications,
sense,
of course.
Because people have unusual anatomy.
Yeah.
Interesting. I think that Tox is still, even though it seems like the easiest, straightforward treatment, probably still got a lot to learn without sort of refining the technique.
Yeah. So, I think for me, I'm going to start having a better look at the muscles around the mouth, the mentalis and the DAO.
Yeah.
Because, we treat these muscles routinely. And yet, of course, if you get a complication, that's pretty significant, maybe for a couple of months for a patient.
Yeah.
So if I could just shove a scanner on, say, the DAO and know that I'm in it, and I can see my needle in it, I think that's a good thing to you can't really ignore that. It's just an easy add-on.
Makes
Got
sense.
the equipment.
Makes sense to me.
So I'm going to be looking into stuff like that. But then eventually, there are people doing it for glabella and frontalis and, standard upper face toxin. If you're that good, why not?
Yeah, exactly. Every opportunity to become better.
Yeah. All right. Well, that wraps up chapter 3 of Trends in Aesthetics. We've had actually some nice feedback. I think people like the more laid back, chitty chatty nature of these ones. Do you have any feedback?
I enjoy them because I love talking to our guests, but obviously just you and I makes it a lot simpler. Things can flow. We've got some obviously come from different backgrounds and mainly disagree on everything. So it's always good to be able to flesh stuff out a bit. But
we haven't had a fight today. Today's been good.
I know. Well, the day we've still got a couple hours to go.
All right, guys. Well, hopefully you enjoyed that one. We shall see you next week for more fun and games.
Take care.
For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloane and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.